Good morning, sir.
Good morning. Hello.
Yes, sir. Good morning, sir.
Good morning. How are you?
All well, sir.
Hope all are fine after the yesterday's party.
Yes, sir. Sure, sir.
Had a good sleep, I suppose.
Yes, sir. We had a nice sleep, sir.
So we are here to continue on what we did yesterday to the surgical session with little more advanced cases. The first case what we are taking is a revision frontal sinus surgery requiring some, extended approach. So regarding frontal sinus, I want to just share certain things with you. Yeah, you kar do. Before we move on to the surgical part. Are you getting the PPT?
Yes, sir.
So once it comes to frontal sinus surgery, you have to be, first of all, well versed with the anatomy, cellularity, and the structures in the vicinity of the frontal drainage pathway, which can complicate the frontal sinus surgery. Frontal sinus surgery is challenging, always considered challenging due to certain reasons. And number one is its strategic location, lying superiorly and requiring angle telescopes to visualize inside. So you have to be well oriented with the angle telescope to do a desirable job. Number two, it's a bone, this sinus is surrounded by important or critical structures, particularly at the level of the drainage by the orbit and the skull base on either side, which are in very close submillimetric distance, and even a slightest disorientation can lead to major complications. Third is you know, the cellularity at the frontal recess is so variable. So variable. Anatomy of the frontal recess is so variable. So you have to be taken to account all these factors, and it requires a good three-dimensional dynamic radiology to get used to it, to identify, to get used to identifying it for particular patient. And here I am sharing you some of the facts, like to begin with the most basic, the uncinate process. One must follow the uncinate process dynamically on CT scan where exactly it is inserting. See all the three, that's the most common phenomena where the uncinate goes upward, joins the medial wall of the agarnage and insert on the lateral wall, that is lamina papyracea, giving a medial drainage pathway. And this is the safest and the commonest, phenomena. In more than 98% cases, you'll find the uncinate going like this. You may still find variation by variation in the agarnage as it joins the medial wall of the agarnage to insert on the lamina. So sometimes agarnage is too big, can push the uncinate. Sometimes it is, very small agarnage and you may not find the upper uncinate insertion fusing with the agarnage. So sometimes it is too big and can push this turbinate to insert on the skull base. This is such a dangerous phenomena. As while doing uncinectomy, you can initially, in the initial phase of surgery, where the first step is uncinectomy, you can give a CSF leak. Similarly, it may insert onto the turbinate as well, and manipulation of the turbinate or manipulation of the uncinate can lead to turbinate manipulation, which inserts on the cribriform plate and give problems. So the basic thing, once you think about sinus surgery, plan surgery, you must be thorough in three-dimensional CT scan to know where exactly your uncinate is going. That is very, very important. And, all these three insertions can give variety of problems. And the most important thing in the radiology, when it comes to radiology regarding frontal sinus, the most important reconstruction is the sagittal section reconstruction. Right? Sagittal sections are most important in knowing the anterior-posterior anatomy and the relationship with the skull base and the beak. This is one of the most important sections by means of which you get point details of the frontal sinus. Like in this is the beak. That is the biggest obstacle. The cell which is inserted on the beak. Beak is forming the anterior wall of the frontal sinus as well as floor, and behind the is the skull base. So this is the agar negi, which is inserted, almost always present on the anterior wall, inferiorly on the beak itself, and posteriorly are the bulla, suprabullar cell, and other variations which are inserted on the posterior wall. And this is best depicted on sagittal section. So by and large, these are the cells in the frontal drainage pathway attached to the anterior wall, like Kuhn described, type 1, 2, 3, 4, and the Aganese cells, and posteriorly the suprabullar we have seen yesterday, frontal bullar, supraorbital cell also we saw yesterday. All these cells are attached to the posterior wall. Intersinus septal cell is a different cell which, you know, makes your frontal recess work more difficult by means of displacing the frontal drainage pathway laterally. And I am going to keep one of the case to show the intersinus septal cell causing difficulty as well after the draft cases. So Aganese are the simplest, as we discussed. The lower cells, the moment you put your endoscope, anything attached to the beak in the frontal recess anteriorly are the Aganese, and you can see this prominence above the level of the axilla. That is Aganese. Those are simplest cells. You can see in these diagrams all Aganese. Adding on to the difficulty, what Kuhn has described are type 1, 2, 3, 4 cells. So Kuhn type 1 is a cell above the Aganese, yet below the level of the beak. Adding on to the difficulty, now you have to go, see, for all these cells attached here, you have to go behind them and fracture them anteriorly, like you have seen yesterday. Go behind the uncinate and fracture it anteriorly. Go behind these cells. That's a safe maneuver, and fracture them anteriorly. Type 2 cones are tear of cells. See the tear of cells attached to the anterior wall. Number of cells 2, 3, 4, but still below the level of the beak. More difficult than the type 1. So you have to individually, take care of all these cells and flush them all with the beak so that your frontal drainage pathway is widened. This is type 2. Type 3 is the cell when one of the cell go above the level of the beak. See this? And that makes the life difficult for the surgeon. Now in order to remove that cell, you have to go all the way above this cell and then fracture it anteriorly. And this beak is the biggest offset. See, you are coming from here, type 3 cell like this, and this thick beak is there. It will not allow you to visualize this, and this will require some sort of drilling of this beak so that you can get onto the cell and the posterior superior wall of the cell, so you can remove it under vision. So this is adding on the difficulty, and this is type 4 cell, when the cell is much above the level of the beak. See the beak, see the height of the frontal sinus, more than 50% of the height or approaching 50% of the height. The idea is to adding on more and more difficulty. This cell cannot be removed without removing this beak. As simple as that. And this will require draft procedure. Can be isolated cell well above. So all these cells can be removed only after removal of the beak. These are the cells which are attached to the posterior wall. See this? Attached to the posterior wall, you cannot afford to go behind and remove them. See, this is suprabullar cell. If it goes further in the frontal sinus, frontobular cell you had seen yesterday. And what you need to do is, you have to remove this anterior wall to flush with the posterior wall, like we simply did yesterday. So these are attached to the posterior wall. Now cell attached to the anterior wall, posterior wall have different attachment, different way of removal. You have to be very clearly knowing what cell is attached where. Another is the supraorbital we discussed yesterday. See the supraorbital cell going up beyond the orbit, behind the level of the frontal sinus. This is frontal sinus is anterior. This is behind the level of the frontal sinus, going above the orbit. Yesterday we did one of the case having supraorbital cell, and this cell has to be thoroughly seen on all variety of whatever CTs can see in all planes to get to the proper diagnosis. This supraorbital cell is important. Sometime one may assume this is the frontal sinus itself. Supraorbital cell is a relationship with the anterior caudal artery, which is immediately caudal to it. So it's a very important structure. One must be able to identify it. Then intersinus septal cell. I am going to keep one of the case for the intersinus septal cell as well, where This pneumatizes the intersinus septum and pushes the drainage pathway laterally. This opens into either of the frontal sinus. On dynamic CT scan, we should be able to see which frontal sinus it is draining in, so that we can widen the access of the drainage into the frontal sinus. That is the treatment for this cell. So I'll show that. Now, this cannot be, the cells attached to the anterior wall, posterior wall cannot be defined very clearly on coronal CT scan, though I told yesterday, see, this is so anterior a picture, you can't see the frontal sinus. What this cell looks, it looks like attached to the anterior wall, could be type 3. This is the level of the maxillary sinus you can see now, and see, it is far behind the frontal recess. See, this was the beak, here there is no beak, this is the level of the frontal recess, and this cell going up looks like frontobular. How can you differentiate? Just put the sagittal section. See, this cell is attached anteriorly and this behind. You can easily differentiate by means of a sagittal section what kind of a cell is what. Like, I'll give you certain examples here. वो देना, वो थी ना इसके साथ हार्ड डिस्क होगी यार. I'll give you certain examples. Just a moment. We need to discuss frontal sinus thoroughly. This is something makes the life of the surgeon difficult. See this, some examples of the supraorbital. I'm just showing you some of the examples, so it gives you a clear-cut picture of what exactly these, variety of cells are. So for some of our patients' example. See this particular scan. See the sinuses, frontal sinus. It looks like 3 frontal sinuses. This is not 3 frontal sinus. See, I am going behind. Now see the value of dynamic radiology. Beak is there. See, if I tell you amongst all these cells, intersinus septal cells are the most anterior cells. Most anterior cells. This is, see where my cursor is, what is this? See this. This is intersinus septal cell, which is communicating with the frontal sinus in the frontal recess level, so behind. See, this is such a big intersinus septal cell, and it has pushed the frontal drainage pathway far laterally, and this cell itself, aeration of this cell is blocked, and you can see the opacity there. Sometimes they make your life so difficult to distinguish. It is your dynamic radiology which can tell you which is intersinus septal cell, which is frontal sinus, and you should be very clear about it. Similarly, this is supraorbital cell. See now, this is your frontal sinus. See the level of the beak. Now, as the beak is going, now the frontal recess starts. See, until here was the beak. That's the most anterior picture. Now the beak has gone, and see things looking like frontal sinus. Same picture of frontal sinus. This is not frontal sinus. This is frontal recess. And what you see, this pneumatization above the orbit is supraorbital cell. See this cell. If I show you in all planes how the supraorbital cell looks like. See how the supraorbital cell. The frontal is far anteriorly and the supraorbital cell is behind. This is supraorbital cell. Frontal sinus is far anteriorly. So this is how you can pick up the supraorbital cell very easily. There should be no confusion in identifying the supraorbital cell. Another example. Another example of supraorbital cell. See this, frontal sinus draining. Now the frontal recess started, and see the big pneumatization above the orbit. That is, now see the cribriform plate in view. The frontal sinus we have left far anteriorly. That is not the level of the frontal sinus. And if you see in all planes, see this. See this, this is supraorbital limitization. The frontal sinus is left far anteriorly. So that is something. See, the frontal is left behind. This is orbit. This is supraorbital cell. Wide pneumatization of the supraorbital cell. See this? The entire supraorbital cell, you can visualize this is above the level of the orbit, pneumatizing the orbital plate of the frontal bone. So we should be able to identify these cells very, very clearly. Another example. See this particular patient, if I reconstruct, see this. See the huge, I remember this patient had a huge intersinus septal cell. And see where it is communicating. See, it looks like 3 frontal sinuses. Where the actual frontal sinus is, see is the beak. See the beak. Now the beak is going, this is frontal sinus on left side, and this is intersinus septal cell, which is opening into the frontal sinus behind. This is opening in the frontal sinus, and that is the frontal drainage pathway. So now what you need to do is, you have to widen this, remove this party wall and widen the drainage of the intersinus septal cell in the right frontal sinus. That is the treatment. See the value of dynamic radiology, you can actually get to know how this cell is communicating to the frontal sinus. If this frontal sinus drainage pathway is widened and this cell is communicated, that's the final answer to this problem. So we should be able to know which one is the frontal sinus and which is the intersinus septal cell. Again, this example in the series of examples, this is one of the classic examples of, frontobular cells, I can say. See this particular patient. Let me show you the coronal and you can pick up what kind of cell it is. That's an important finding. See, I will run the CT scan and show you. See the frontal sinuses? Frontal sinuses, absolutely no cell so far. This is the clue. See, right from anterior here, no cell so far. Now see carefully, carefully, carefully. Can you see some cell appearing in the left side? Hello?
Yes, sir.
See this cell appearing in the left side in the frontal recess region. Looks like isolated cell. See this cell. What it could be? See this, where it is attached to. How to see? How to confirm? See this cell, and I take my cursor into it, and you see there. This cell is actually a frontobular cell attached behind. That is the drainage pathway anteriorly. There is no anterior attachment. This is classical example of a frontobular cell obliterating the frontal sinus drainage pathway from behind, like we saw yesterday, and you have to flush it to widen the frontal drainage pathway. So there are many ways you can identify all these cells, and that's how these cells can be easily addressed, not complicating your course, surgical course. Now see carefully what kind of cell it is. First, let me show you coronal. Wait. See what kind of a cell it is. Again, I am showing the example. Anteriorly, no cell, no cell, no cell. This is intersinus septal cell, most anterior one. See, pneumatizing the septum. Can you see clearly? And this is opening to the right side. Clear?
Yes, sir. Yes, sir.
Now see some cells appearing on the left side. When posteriorly, when the drainage pathway starts. Posteriorly cell coming means these are attached to the posterior wall, not anterior one. And that is so important. The beauty of this dynamic radiology, you can change your window settings as well. Now see, if I focus on these posterior cell, you will find See this? These cells are attached posteriorly. These cells are attached posteriorly. See, this is projecting into the frontal sinus and making the life of the surgeon difficult. And sometimes, because of these cells, once you see something big in the frontal sinus region, one can easily assume this could be the frontal sinus. So, frontal sinus, surgery is